The issue of a medical home is something that I've personally been very interested in for several years, and that we as a center have done quite a bit of work on from a health services research perspective. As you know, and I hope I'm not stealing any of your thunder, Tom, medical home is a construct that has been incorporated into the Affordable Care Act and is a required component of some very key pieces of the Affordable Care Act to improve not just coverage, but also care, the quality of care that people in this nation get as a result of their coverage. And I think, so I guess when you change slides, it'll be okay. We won't have the screens later. Dr. Thomas Klitzner is an excellent person for us to hear from about the medical home. This is something that is also quite a passion of his. He is the Vice Chair for Academic Affairs in the Department of Pediatrics, professor there, of course. He's the Director of the California Children's Services Programs at UCLA's Mattel Children's Hospital. He's the Director of the UCLA Pediatric Medical Home Program. And he runs a renowned pediatric cardiology program here at UCLA. And so it's a great privilege to have Dr. Thomas Klitzner speak about this issue. And I know we will have time, even though we're starting a little bit late, we will have some time for questions and discussion.
Thank you. And thank you, Rick. I think rather than stealing any thunder, you actually set up what I'd like to do very well. I had the opportunity to take a year off last year on a sabbatical to take a look at issues related to healthcare delivery for children in particular, and of course my interest being a cardiologist, children with chronic and complex disease. It happened to be a very good year to do that because the Accountable Care Act passed in the summer before. And so there was a lot of activity around how the delivery system could be redesigned, and obviously the debate has continued. But I came to this from cardiology because I became very interested in primary care for children with complex disease, and that's the genesis of the Pediatric Medical Home Program at UCLA. What the actually, Rick, if you could do me the same favor and move to the center, I think that would help me.
Sorry.
Thank you. The year of study, I would call study, contemplation, speculation, and gathering of knowledge really helped me place the medical home concept into this broader context. So what I'd like to do is, first of all, talk a little bit about medical homes, where they come from, where does the concept come from, a little bit of the history. And then tell you about my program, briefly tell you about my program and some research that we've done here in the Department of Pediatrics. And finally, to try and move this whole concept forward into the era of healthcare reform writ large. That doesn't necessarily mean the Accountable Care Act. It means the Accountable Care Act is part of it. Our California 1115 waiver, which is our ability to redesign our Medi-Cal system here in California, is part of it. Some of the ideas that have been put forward by Don Berwick at the Center for Medi-Cal and Medicaid in Washington is part of it. And also, I think, just forces that you're seeing around the country reshaping the way healthcare is delivered. All of that together, I like to think of as healthcare reform because it gives me just a term to mean everything that's going on. So, we have to start with a very brief history of medicine. This is very brief, and it happens to be seen through my eyes, but I think it'll give you an idea of what's happened and why the medical home developed. So, if you go back to before World War II or during World War II, really this started happening. Before World War II, medicine was very, very different than what we see today. It was actually practiced by general practitioners who, interestingly, had a lot of the characteristics of what we call a medical home today. And my favorite example of that is a doctor who doesn't exist. He's fictional. His name is Sam Abelman, but he's the protagonist in this book, The Last Angry Man by Gerald Green. I recommend it to you if you want to get a flavor for what medicine was like in the 1940s and 50s before we really had specialties and specialists. In fact, one of the very interesting scenes of in this book is diagnosis of this was an area of New York that was ethnically diverse, very poor neighborhood, and a young man gets cancer. And really, the best that Sam Abelman can do for him is to sort of cajole his friend at a nearby hospital who has a new x-ray machine, because no one had x-ray machines, to do an x-ray so they can see if they can see this thing, but there's nothing they can really do about it. And what he does is spend a lot of time with this patient at his bedside and at his house, and helping him through this very difficult period. So, starting though during World War II, actually, what we saw was an explosion of medical technology, and I've made a list that I kind of use just to reference the things that are some of the landmarks people know about, but penicillin came in 1942, Salk polio vaccine, which some of us in the room took in 1952. 54 was the first solid organ transplant, and 58, external pacemaker. Oral polio came in 62, and the first human heart transplant in 67. So you can already see by 1967, which is before my medical career started, we were already seeing the kinds of medical advances which we now would just say are commonplace foundation of what we do at Reagan Hospital and Mattel. But what this resulted in is a fragmentation of care, because the specialists became more and more specialized and worked more and more on these more complex technical problems, the less we had the Sam Abelmans of the world who saw the whole patient and pulled everything together. I like to say that in the Division of Cardiology here at UCLA, we have doctors who specialize in the valves guarding the left side of the heart, and that's what they deal with. And God bless them, they do a wonderful job, and they can do things with those valves that were unheard of even 10 years ago. But you can see how that leads to fragmentation of care. So this is a definition of the patient-centered medical home, which I really like. I don't think it's necessary anymore to say it's not a building. It's a place and a system of care, and this definition is called the healthcare setting, that facilitates partnerships between individual patients, their personal physicians, and when appropriate, the patient's family. Now, in pediatrics, it's pretty much always appropriate for the patient's family to be involved. Care is facilitated by registries, information technology, health information exchange, and other means to assure that patients get the indicated care when and where they need it and want it in a culturally and linguistically appropriate manner. And the cultural and linguistic part of this is extremely important and something that is maintained in our medical home program today. So how did this all develop? Well, back in about 1967, the Committee on Clinical Care of the Academy of Pediatrics introduced a concept they called the medical home. What they actually meant at that time was just one place where the patient's entire medical record was kept. And you can see that this works pretty well with that explosion of technology we were seeing, because if you started in the academy in the 40s, you probably didn't need this. The medical record was in the pediatrician's office, and that's all there was. By the time of the 60s, when we had heart transplants and all of these other advances, the care was now being fragmented and the record was fragmented equally. And so that's the way they looked at it. But it was in 2002, and really the father of all this is a physician named Calvin Sia from Hawaii, who operationalized the medical home through legislation in Hawaii. I've been lucky enough to work with him. He's still a wonderful guy. He's 84 years old. He flies from Hawaii to Washington or Chicago or wherever we're having meetings, and how he deals with jet lag, I can't figure it out, but I guess he's just one of those people who believes in this passionately and continues to work on it. He authored, along with others at the Academy of Pediatrics, a policy statement in 2002 that basically set forth the principles of the medical home the way we know it today. And they include these important operational characteristics: the care be accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. Now, recently, there's been a lot of talk about the medical home, as Dr. Brown said, and everybody's got a statement now. The American Academy of Family Physicians put out a statement. This is just a list of statements, for which I can get you references if you like, or you can look them up on what the medical home was. So in 2007, family physicians, pediatricians, the College of Physicians, and the osteopaths got together on a joint principles statement. And I don't have a copy of the joint principles statement because I actually like the Academy one better, but that's also on the internet, and it basically says the same thing. It adds some things about payment, which I think are important. So, 2002, the Academy of Pediatrics had just come out with this statement on the medical home. I became interested. Actually, I got a huge chart delivered to me because I had a sign for a formula for a kid or something like that. And I couldn't figure out what to do, and I went through the thing, and I noticed that one of our pediatric residents' name was pretty prominent in the last few years of the chart. And so I called him, and I said, "Hey, Sean, I've got this chart in front of me at 6 volumes, and I'm supposed to sign for a special kind of formula. Do you know why this kid needs this formula?" And he said, "Well, of course I do. I mean, it's this, and this is the reason, and here's what's going on." And he gave me a whole little summary, and it became an idea of mine that we could, in our resident clinic, teach our residents, or take advantage of the fact that our residents were the primary care doctors to many of these very complex kids, and were the people who understood what was going on with them. So the medical home, what's now the medical home program at UCLA, began as a 5-year project funded by Healthy Tomorrow's Partnership for Children. That's the Academy and HRSA, Maternal Child Health Bureau. And it does now, and it always has been a program in the general pediatric resident continuity clinic. And we've set the thing up, or at least we did initially set it up, so the patients enrolled in the medical home receive all their care at UCLA. They tend to live in Los Angeles, well, they have to live in Los Angeles County, get their subspecialty care, and that becomes important as we started to do some research on them. So here's how we set this up. And I have to say, and I came from the basic science research world. I have a PhD. I did heart cell research, and so I believe in controlled experimentation. And so we set this thing up as a sort of laboratory to look at how these kids receive their care and how we might improve it. So the patients had to be eligible for the CCS, or California Title V program for children with chronic conditions. That's the California Children's Services. They had to see a minimum of 2 pediatric subspecialists, because again, we wanted the most complex kids. We didn't include solid organ transplants because those tended to grow up in transplant centers that provided most of this care, and general pediatricians tended not to be as involved. And then, for a variety of reasons, we excluded adolescents. That actually turned out to be a very good thing to do scientifically, not a very good thing to do from a program point of view, so that's one of the things we're actually doing now, is expanding to adolescents. Our initial look at this population used the hypothesis that care coordination using a family-centered medical home can decrease medical resource utilization while achieving high satisfaction scores. And what we did was we enrolled an early cohort of patients, got IRB approval and all that. And we then were able to look at their utilization data because they got most of their care, virtually all their care at UCLA. We could go into the UCLA administrative databases and look at all of their care for a year before their enrollment in the medical home and a year after. Now this eliminated some patients. Anyone under a year of age, for example, couldn't be in the project. So of the initial 41 patients, 30, we could get data on 30 of them. And this tells you a little bit about the patient mix. It isn't exactly the same population, but of the first 20 patients we enrolled, you can see about half spoke English, about half spoke Spanish, And then there were a variety of other languages that got mixed in. At this time, it was Portuguese and Zapotec. Zapotec is one of the indigenous languages in Oaxaca. You have to have two translators. Someone translates from Zapotec to Spanish, and then somebody else from Spanish to English. It's quite interesting. And you can see that a lot of these kids came from one-parent households, and the gender split was sort of what you would expect. But their illness severity, their illness burden was pretty high. I mean, of the 30, and this is 30 in the study, only 9 of them saw 2 subspecialists, and the most of them, 11, saw 4 subspecialists, and there's even one kid who saw 6 different subspecialists. So this is a very high utilizing population. Partly, I have to admit, the research was designed that way because I thought if they're really high utilizing, maybe we have a chance of showing something. It's just a basic principle I learned in physiology. And here's what we did for them. And this is basically all we did for them during the study period. Rather than their usual 20-minute pediatrician visit, they got one 60-minute visit, which first served as an intake visit where we developed a problem list, introduced them to the team, which was one person, and introduced something called an All About Me binder. But their follow-up appointments were 40 minutes instead of 20. So there was extra time at those appointments to do the medical home sorts of things, and it had 2 advantages. One was there was more time. The second is the residents liked it because they were seeing a patient every 20 minutes, and it was hard for them. So by acquiring medical home patients, they broke up their day a little bit and could spend 40 minutes with the patient. We hired a family liaison who was an administrative level person who spoke Spanish, attended most appointments, coordinated follow-up and procedures, native Spanish speakers, and they were recruited because they had clinical care coordination expertise somewhere in pediatrics at UCLA. We also gave them a book called the All About Me binder, which included a lot of pages of what their medical records were, what their medicines were, who their contact people were, and they would carry that to all of their appointments. We also gave them a little bag with the medical home logo on it so they could carry it and be identified. But the data collection, as I said, we identified all inpatient and outpatient encounters in the electronic medical record for a period of 1 year prior and 1 year post enrollment in the medical home. So it's not the same year. For each kid, the year starts 1 year from before their enrollment appointment and ends 1 year after. And we looked at outpatient continuity clinic visits, urgent care clinic visits, emergency department visits, and inpatient admissions. And here's what we found. And this is pretty much mirrors other research that's been done in this kind of program. The ED visits dropped from 1 per patient period to a half per patient period. There's a 55% decrease in emergency room use. Urgent care visits, pretty much nothing happened with them. And outpatient visits in general look like they might have increased. Those are scheduled outpatient visits. We didn't really have the numbers to do this. But that's what you would expect. If you're coordinating care well, the kids show up for their regular scheduled outpatient visits and they don't go to the emergency room. Hospital admissions, we saw absolutely no change. And we hypothesized these are just sick kids. They need their surgeries. They need their... we did see some effect on hospital days, and I think that's where we may get some result. We also were able to look at family satisfaction, and I'm just going to skip through this because this is a methodology that is specific to the medical home, but there's something called the Medical Home Index, and we could administer it either English or Spanish. It had questions like, when I call the office, does the staff know who we are? Does the staff respect our needs? If you add up all these questions plus sub-questions, there's 30-some questions, and this graph just shows 0 means we did exactly as well as national averages. There's 1 on which we did less well, or I'm not sure this is statistically significant. I'm not sure which one this is. But you can see our scores were very high. The parents really appreciated this program. And of interest, we compared our Spanish, now this is submitted for publication, we compared our Spanish-speaking to our English-speaking patients, and the Spanish-speaking patients actually scored higher on these satisfaction measures than the English-speaking parents. For those of you who look at disparities kind of research, this is pretty much unheard of for Spanish-speaking populations to score equal or higher than English-speaking populations in the same measure. So what we conclude is that while complex patients will always require substantial outpatient, inpatient, and inpatient care, a comprehensive system of care coordination such as the Medical Home Project at UCLA can reduce medical costs by decreasing medical resource utilization while achieving high family satisfaction. Differential effects of language on family satisfaction can be eliminated by providing family-centered bilingual care in the setting of a medical home. So again, we believe that this cultural sensitivity, language competence is part of delivering a comprehensive care, and as I said, we're just publishing this now. Now, interestingly, we had a parent advisory group that met. We were going to have them meet every other month because we thought, well, this is hard. They've got lots of kids. They take buses. They wanted to meet every month, and so we met with them every month. On 1 month, we would give a presentation maybe about Medi-Cal or about IEPs in the schools or other things they need to know. And on the alternate month, they would give us feedback, and we asked them about the finding of the emergency room decrease, and this is what they said. They said they found that the program can catch problems early so that they weren't ending up in emergency rooms, that the parents didn't freak out. And this was a really big issue for these families, that often the mom would be at home with the child, dad would be at work with the car, and the child would get a fever, they wouldn't know what to do, dad would get home, and around dinner time, and all that was available was an emergency room, so they'd go. With a medical home, they learned to call in. If we needed to provide transportation to get them in, we did, etc. More structured follow-up is obvious. Navigating the medical system, I think, is a huge part of it. And then empowering parents to become part of the team is now a concept that's very well ingrained in the whole medical home, that it's a shared partnership with parents, care providers, specialists, schools, community, but the parents, or in the case of for adults, the adult themselves, the patient themselves, is part of the team. So this is our medical home team. These are all the people that worked on it here at UCLA, and of course I want to acknowledge them. But I think that where this fits into healthcare reform and the changes that we're seeing in the delivery system come in the future. And here are some things that are actively going on now. We're expanding our program to include all children with special healthcare needs in the UCLA Continuity Clinic, and we partly want to determine the scalability of this, because running a 30-patient program is nice, but obviously you can facilitate things in a 30-patient program, you can't in a larger program. And second, we were through the 1115 waiver, there was something called the Delivery System Reform Incentive Pool, so we were able to get some money to fund a pilot expansion to extend the concepts not only to children with the most complex disease, but basically to all children. And I'm going to tell you a little bit about, in theory, how we plan to do it, although as of today, we're actually hiring people into that program, and it's starting to expand. So this is delivery system redesign is happening against a background of changing demographics in healthcare. And this is extremely important because I think the way we look at the healthcare delivery system depends on who the patients are, and who the patients are is changing. So first of all, costs are rising. Everybody knows that. But the population as a whole is aging, and that's important. People are living longer. That's also important. And the percentage of patients in the general population with chronic disease is rising. That's partly a function of people getting older. But in pediatrics in specific, the percentage of patients with special health needs, that means requiring more than the usual amount of medical care, has grown from about 10 to 12% a decade or so ago to, by some estimates, if you include various forms of mental health, 36 to 40% now. So the special need, the population requiring special types of programs has increased significantly. In general, the population is older in kids as well, because even in the 1960s and 70s, kids with fatal illnesses just died. So they died out of the population, and their utilization and needs went away. Now they're living to adulthood, creating two problems. One is we have to transition them to adult programs, which I'm not going to talk about, but it's an interesting question. But also just to increase the percentage of kids with chronic disease in the population, because they're living longer. And the older patients we're finding are often sick because they, for instance, had their heart surgery 20 years ago, when we do the same heart surgeries we're doing today, but they're now teenagers, and the surgery they had wasn't designed to preserve their heart function for 40 years. It was designed to get them to live for 3 years, and that surgery may or may not be the best way to function as an adult. And then Also, pediatric hospital beds are decreasing. I don't know the trends in adult medicine all that well, but we're losing pediatric beds in LA County like crazy. Part of it is downsizing that took place in the 90s. Part of it is that hospitals that were general pediatric hospitals can take care of a kid with diarrhea, can't take care of a kid with cancer. So the kids with diarrhea are all being treated as outpatients, and these are all issues that we have to face. In general, the take-home lesson of the demographics is that patients are becoming more complex, and in pediatrics, they're becoming extremely more. The complexity is increasing in an extreme way because of this living to an older age. So this is one of my favorite slides, and I made it myself. It's not real data, and it's not usually displayed this way, but this is a utilization curve. And the utilization curve, the way you make one of these is you pick a period of time, let's say a year, and you take a patient population, let's say everybody insured by Blue Cross in LA County, and you look at the cost of the actual cost, not the charges, but the cost of their health care over the period of the year, and then you line them up so that, in this case on the left, is the most expensive patient in the group, and on the right is the least expensive patient in the group, and you just make a bar which indicates their utilization. So this number here, this is the most expensive, well, the most expensive patient in the group goes off the chart, which is always going to happen. But about $200,000 is an expensive patient for a health plan in general. So that's an approximately right number. But you can see that the intensity of cost or the intensity of service drops off pretty significantly, and then you get this very flat portion of well people who don't use much health care, in particular on a scale that's in 50s of thousands of dollars. They look like zero. This is really important for health care reform payment mechanisms for two reasons. And one of them is this long flat tail, even though there's not much cost down here, it has lots and lots of people in it. So if you do the average cost of this whole population, it's going to come out on the flat part of the curve. For a general population, it always does. That's nice because that's going to, if you're going to get paid in a bundled format rather than a fee-for-service format, you're going to get paid about the average cost of your patient population, and it's down here at the low numbers, which makes insurance companies happy. But there's actually a much more important reason why this is important, and that is there's variance. In all of these calculations, there's variance. And if you're down here on this part of the curve and you pick this point and you're off by 5%, well, if you move 5% this way or 5% that way, nothing changes very much. There's just not a lot of variance down around the point that's going to be your mean point. For very sick populations, if you're up here and you miss by 10%, that's going to break your program because the cost variation for missing for 10% is going to be up there, and you won't be able to run it for the bundled payment that you're getting. So that's how these curves are used. I think that they're very interesting, and I've thought about them quite a bit. I'll show you one of the other things you can do with them toward the end of the lecture, but there's a lot you can do with this kind of information. So anybody know who this guy is? So that's Attila Gawande. So my thinking in this, and I have to say, the paper showing the 55% reduction in healthcare costs, in ER utilization got published, and I just thought it was great. But it's a population of 30 patients in a pretty controlled environment. I wasn't quite sure what to do with it, and I started reading Attila Gawande, who I eventually got to meet. He was out here last year, and I actually started an email correspondence with him. But he has a number of very important concepts, but the two that were most important to me are in these two things that he's written. One is, one is the Hot Spotters article in the New Yorker from January of last year. I'll talk a little bit more about it, but he talks about programs that specifically look at small populations that are high utilizers, and I think that probably is part of the healthcare delivery system we ought to take a closer look at because it's where all the costs are. He also talks in Checklist Manifesto, which I recommend to you if you haven't read it, probably the single best book on healthcare reform that you can read, and what he's talking about is the development of checklists, and that part of the book is fascinating, and what he did is unbelievable with development of checklists. But in order to set up the checklists, he also talks about complexity, and I think that this is a really important concept that if you don't take anything else out of this, patients just aren't created equal. They tend to vary quite a bit in their needs and in the severity of their disease. Now, this is a simplification of a much more complex scheme that we actually use in the medical home, and I'll show you how. But basically, Tier 1 are simple problems. Simple problems have low cost and other characteristics that I'll show you. Tier 2 are complicated problems, and the cost there is moderate. And Tier 3 are complex problems, and the cost is very high. Now, what do I mean by this? Well, a simple problem is the example that a lot of people use is baking a cake out of a Betty Crocker box. It's solved by following a recipe. If you have a good recipe and you follow it, you get good results, and you don't require any special expertise to solve this problem. In medicine, some of the examples come out of minute clinics. I don't know if you guys have looked at minute clinics, but they're a fascinating phenomenon in healthcare delivery where you can just walk into a drugstore and have a rash diagnosed, or I went with my daughter to have swimmer's ear diagnosed. Well, those are simple problems. I mean, if you know what to look for and know how to develop a differential, which, by the way, computers in the minute clinic do, you can get excellent results without much expertise in a lot of these problems. I think they do urinary tract infections also, things like that. Complicated problems are more difficult but they still involve a sequential linear process, and a single system is involved. In the writing I've done about this, the diagnosis of a pneumonia, I think, fits this pretty well. The clinician hears rows, sounds in the chest, thinks there's probably a pneumonia, does a chest x-ray, which is the next step in every one of these. If they can't figure out what they're seeing exactly, they involve a radiologist who's trained in reading chest x-rays. The two of them together develop a differential. If the differential includes bacterial pneumonia, they might do a sputum culture, prove it, give antibiotics. So it's a linear process involving one system. A high level of expertise in a variety of fields is needed. You need both a clinician to hear the breath sounds, which is not that easy to do. You need a radiologist trained to read the chest x-ray. Those two need to communicate, but they're still operating in a linear process. Replication of success is expected, and that's actually still true in pneumonia treatment today, although we have bacteria around that no one understands very well, unfortunately. And there's a high degree of certainty of outcome. We treat bacterial pneumonia quite well. Complex problems have simultaneous processes going on. The one I usually refer to as organ transplantation. You've got one team going out and getting the organ. You've got another team prepping the patient. You've got another team matching the organ to the patient. You've got psychosocial teams making sure that the patient and family understands what's going on. And that's not counting anesthesia, ICU, and everybody else who's simultaneously working to solve this problem. There are usually multiple systems involved. Expertise is necessary but not sufficient. And this is really one of the take-home messages of Checklist Manifesto, is that if you're involved in a complex problem, you need communication and coordination as well as your linear checklist. Fascinating, but for those of you who follow this field, you know that making an airplane take off is the example of a complicated problem, the linear problem involving three people in the cockpit all talking to one another, but it's a linear process and you can use checklists. Gawande uses building a skyscraper as the complex problem where you're putting in walls and plumbing and electricity simultaneously, and gives the example that when they run into a problem building a building, what they do is stop. Everybody who touches that problem gathers at the site of the problem. They all discuss it. They all agree on one solution. They sign off on it, and then everybody goes back to their individual process. Well, imagine how wonderful it would be if we did that in medicine. I mean, it is the basis of what he calls a huddle, and he's also responsible for huddles. But huddles are only a sort of miniature form of this. If you have someone getting a heart transplant and you've got to coordinate all that, getting all those people to talk to one another if you run into a problem, it almost is impossible. It just doesn't happen. So I think that one of the problems we've had in medicine, and I saw one of the first presentations on quality improvement here, and it was race car drivers, team of race car drivers changing a tire on a race car that comes into a pit stop. That's a complicated problem. It's not a complex problem. And one of the pitfalls we run into is that we treat complex problems as if they were merely complicated. And that's a problem because it leaves the communication piece out. One of the things the medical home puts back in, or tries to put back in, is the communications piece. So here's how we define our tiers of care in that scheme in our newly expanded medical home. Tier 1 is well children and children with acute illnesses. These are all children who are going to have only episodic visits. Nothing lasts very long. Even complex broken bones are less than a year, and we usually use a year as a cutoff. Tier 2 is children with a single chronic condition, that is a serious condition like heart disease, like asthma, like diabetes, but it in general resides in a single organ system, but it lasts longer than a year. Many of them are lifetime diseases. And Tier 3 children are our medical home patients that we built the program on, children with multiple complex medical conditions. And you can start to see the relationship of these different groups of patients to the simple, complicated, and complex scheme that Gawande puts forward. Now, this is an interesting just sidelight, but I also was involved in the process of trying to develop the elements of a medical home across 5 domains, and plan of care and follow-up is just one of the domains, but it illustrates what happened. We brainstormed in a large group of experts what Tier 3 patients would need in order to have a medical home program, what Tier 2 patients would need, what Tier 1 patients would need. And you can see the Tier 1 patients, your well patients, really just need an individual care plan, and we've now added registries to that. And that's pretty much what you need to give good coordinated care to a Tier 1 patient. Interestingly, not unexpectedly, Tier 2 patients require more. But everything that the Tier 2 patient needs builds on what the Tier 1 patient needs. And everything that the Tier 3 patients need build on Tier 2 and Tier 1. So what we're in the position of doing now is deconstructing our Tier 3 medical home and figuring out which of those elements belong in the Tier 2 patients and which ones move all the way down to the Tier 1 patient. But it's all a unified system. So this is a major question that many people are asking, but I know CMS is asking. There's a meeting next week in Washington about it. Is can the system improve value? Because it's not just a matter of can we make the kids, satisfaction of the families better, and even can we make medical outcomes better. This is one of the things that Michael Porter says, and I don't know how many of you know Michael Porter, but my 2 favorite business people are Michael Porter and Clay Christensen at Harvard Medical School. And they've both written very interesting books looking at the healthcare system. One, I think Michael Porter's co-author, Elizabeth Olmsted, has a child with heart disease, and I think Clay Christensen himself has diabetes. I'm not sure, but they have interactions with the medical system that allow them to look at this in a certain way. The one thing that Michael Porter says that everyone pretty much agrees on is this thing called the value equation, where what we're trying to do is increase value by either increasing outcome or decreasing cost, or both. So that's sort of where I see the medical home playing a role, because I think we can get better outcomes and I think we can get them at lower cost. Now, this is that utilization curve again, and the way this fits here is another project that I'm working on is we're about to start a program of taking a bundled payment, or a PMPM payment, for kids with chronic disease through the California Children's Services Program. In order to do that, the program analyzed, some researchers analyzed program data using utilization curves to tell us about where the utilization was. What I'm going to tell you is fairly typical for systems containing complex patients. In the CCS program, which is already, you have to have heart disease, cancer to even be in the program, even within that program, 10% of the kids are utilizing 90% of the resources. If you read Hotspotters in the Camden program that he talks about at the beginning, 1% of the patients are utilizing 30% of the resources. We used to talk about 80-20 splits. Because of the changing demographics, the splits are actually much more of a step function than that. There may still be some healthy general populations where the utilization split is 8, meaning 20% of the patients use 80% of the resources. You'll hear that said a lot. They're actually in patients containing complex and chronic illness, which, as I said, most populations are these days. you find the splits are more like 1:30 or 90-10 and things like that. So what I've done is just sort of taken a look at this for kids, and in the top 5% of utilizers are basically our CCS program. Our kids with chronic and complex disease, complex in the sense that they may have a single organ system like the heart, but it requires surgery, etc. This is a very interesting population. I have not figured out how to parse it correctly yet, but there are clearly people at the top end of this spectrum for whom there is no delivery system that's going to increase value. These people are just sick. They're going to use dollars. The actual appropriate, it seems to me, mechanism for dealing with them is something called reinsurance, where you just find someone who can pay large amounts of money because they have large pools of these patients, because there's no way you're going to be able to reduce their utilization. But in the bottom half of this top 5% are my medical home kids. I know you can reduce utilization for them. They're at the Camden Project, people are in there, where they were able to reduce costs quite significantly by approaching this very top tier. Then you get about the next 15% are your tier 2 patients. They're basically the chronic diseases that we're all familiar with. People with asthma, people with diabetes, people in adults congestive heart failure, single organ, fairly complicated but not complex problems. And they still represent a fair amount of healthcare expenditure, but nowhere near as much as the top 5%. And the bottom part, which is 80% of the population, are those who are well or have only episodic acute illnesses, and they don't cost very much at all. So what I believe is you have to design the system of care so that it takes into account this split between the very complex patients, the complicated patients, and the more simple patients. And I have several schemes that I've developed over the last year that describe this, but here's one just to give you an idea. In 0 to 5%, in that very complex patient population, we've added reinsurance, which isn't on this slide. But this is where care coordination and special programs of care management, like hotspotting, like my medical home program, are very effective, and they become cost effective because even though they have a fair amount of resources involved, the amounts of money you save are huge. And so they pay for themselves over and over. And I think that this population is not that large. I've done some estimates here at UCLA. We think we care for about 400 of these patients out of the several tens of thousands of kids we care for. Well, for 400 patients, I know that one of my family liaisons can handle 100 patients. So we're now just scaling up to 4 family liaisons. These are AA2 people. I don't know how many you know the UCLA salary scale, but that's just a little over $100,000 of investment to save 50% of the cost in a population that's using 90% of the utilization. I mean, it's kind of a no-brainer to me in that area that this is a place that we should be looking. The 5 to 20% is where you've heard a lot, and there are very good things, and we're starting to do this now, which we have not in our medical home. But here's where patient education, something called shared decision making. This is a concept about how you work with patients to help them learn enough about the disease so they can really understand what their options are, and they just don't go to a surgeon who says, you need an operation. Someone actually explains the operation, the risks and benefits, and a lot of patients actually go for more conservative therapy and do quite well in shared decision making. Chronic care management's been around for a long time. We have a very interesting heart failure program here. I don't know if Mike Ong has come to talk about it, but how you manage heart failure at home with an individual patient and keep your group of patients out of the hospital. But these are the things that are effective in my reading and experience in the 5 to 20 percentile. In the 20 to 100, in the well patients, the emphasis is on community-based care. And community-based care basically means these are the ones who for sure should be getting their care in their community. And quite honestly, I have to admit, I'm one of the few physicians who's agnostic about how that should happen. I think good managed care programs work. Safeway Health, which is an employer-based program, works pretty well. I actually think Medicaid managed care works, or managed care in general, but Medicaid managed care that I know pretty well because I'm on the board of one of the healthcare firms. It works pretty well in this. I think minute clinics actually have the potential to make a contribution in this group. I mean, there's lots of things you can do down here. You're not going to get much value because the patients aren't that sick, so the outcomes are all going to be good, and they don't cost that much, so you can't reduce much. But if you want to have a satisfied patient population, the things that satisfy people who aren't very sick is getting care close to home, having someone who speaks their language. It's a lot of the things that principles from the medical home, but they're not the complex care principles. So this is a slide that I borrowed from Carl Cooley. Carl Cooley runs the Center for Medical Home Improvement in New Hampshire. He's a pediatrician who's one of the best thinkers about the medical home that I've met. His institution developed that medical home index. But just to give you some idea of how you could structure something like this, and this is really his idea, but if you look at these categories of children, and this is now the pediatric patient-centered medical home. So you have the well children who require only preventive care. These are the tier 1 patients, which represent the largest part of any pediatric practice. Then you have children with acute illnesses. And then you have children with a chronic medical condition. So in the scheme we've been talking about, these are all tier 1 patients. These are mostly tier 2 patients with a smattering of tier 3 patients, because if you're out in a community practice, you just don't see that many kids with complex disease. But if you look at the tasks that are required under each of these categories, well children have health maintenance visits. This is like well women visits. They go to the doctor merely because they're developmental checks and immunizations and things they need. And they get screening and guidance. So we're looking for, can they hear, are they learning to speak, are they developing normally? Children with acute illnesses require acute illness visits and therapy. I mean, someone needs to look in the ear to diagnose an ear infection. Telephone triage is very important in this area. And then acute illness follow-up. If we treat it with antibiotics, did we cure the disease? And up here, for chronic medical conditions in the pediatric patient-centered medical home, they have to screen for the chronic illnesses. A great example of this is ADHD. ADHD actually falls in this higher part of the spectrum. But if you don't make the diagnosis, then you can't get the appropriate treatment. Development of care plans and coordination, and co-management with specialists. This is something that I'd like to spend a few moments on, because this is the area that we're working on. I just had a meeting this morning about developing 3 co-management chronic care programs between our specialists and our pediatricians. And co-management means that there's a role for families and patients, for primary care and for specialists. And this works for all complex and complicated kids, or all tier 2 and tier 3 kids. What's important about co-management, and this is the system we're now in the process of setting up, is roles are explicitly defined, so everyone's on the same page. If I'm the cardiologist of this child, it's my responsibility to adjust the heart medicines, and I'll let everybody else on the team know what I did, but that's mine. If it's what the child should be eating, that's the general pediatrician. Nutrition development tends to fall with the general pediatrician. That person should let me know what they're doing, but we know those roles or those decisions fall in this other category. And in fact, in a true co-management arrangement, we actually write up a little contract saying, I'll do this and you do this. There is also a process or system defined communication and document roles. This is just that communication thing from Checklist Manifesto. And importantly, and this is a hard concept for people who like systems that have trains and boats and stuff, the roles change. I mean, a kid in the first 18 months after diagnosis of leukemia sees their specialist a lot more than they do 5 years later when they're in remission. And so there has to be some accommodation for these roles to change. This is just a picture that I love. This is from our grant to the state to expand the medical home. And it basically shows a concept that I really like. We're going to have in our pediatric medical home tier 1, tier 2, and tier 3 patients. We always put the patient and family in the center. And then we're going to help them relate to chronic care management programs, asthma, diabetes, obesity. We just added irritable bowel syndrome and inflammatory bowel disease, which is another one that's great for this kind of co-management structure. And then their community resources, schools, our community partners, regional centers, family resource centers. Also out here is their specialty care. And we try and relate to all of these different bubbles in the same way. FQHCs and community practices are going to be part of it. There also is times when these kids end up in the hospital, so we have to have an inpatient-outpatient arm. And then they also, the sicker ones, spend a significant amount of time in intensive care units, so we put that on as well. So I'm basically at the end of what I prepared to say. I just want to go over some of the take-home lessons that I've taken home from this work that I've been doing and tried to encapsulate here. It's an evolving concept. I think that, and I have started to say this in a lot of venues, I think that you can have a medical home without an integrated system of delivery. There are still a lot of pediatricians who are functioning as private practice, fee-for-service pediatricians, standalone group practices that are functioning as medical homes without being part of an integrated system. What I don't think you can have is an integrated system without a good medical home. It's just not going to work. And everyone that I've studied and read about has some form of care coordination, usually primary care, medical home at the center of it. Even the very fancy MD Anderson Mayo Clinic fly-in for chronic disease have that piece to them. Then, as I've tried to point out, evidence is accumulating for the potential of the medical home to increase value for the most complex patients by lowering cost and improving outcomes. That's basically the research that I've done. And finally, I think this is really important. The medical home provides a structure for redesigning the role of specialists, primary care physicians, patient families, and I've started to add into this other medical and community professionals for actually defining what segment of the care population and what part of the care each person is responsible for. And I think that that's actually a contribution that I don't think the medical home set out to make when the concept first came about, and I don't know that there are a lot of people that recognize this potential. But I think it's terribly important. It's terribly important because of a concept that I'll just introduce at the very end. If you want to hear more about it, if we have a few minutes for questions, we can. But those of us nationally involved in this believe in a concept called practicing at the top of your license. It means that every practitioner, no matter who they are, should be up at the most complex, the highest on the complexity scale that they can function. And the reason for that is pretty simple. Those who function at the highest end of the complexity scales are people like cardiac surgeons and neurosurgeons. There's very few of them, and what they do is very, very specialized and very complex. And then the rest of the medical system looks like a pyramid under that, with lots of different people, but specialists and general practitioners and physicians' assistants and care coordinators. With medical assistants is a big one we're starting to use here. Well, one of the things about a pyramid is you can't fill it from the top. You've got to fill it from the bottom, and we've already started to develop gaps in this pyramid because the specialists are all moving way up to the complex end of their the complexity spectrum, and the general pediatricians have lagged back and still want to give immunizations and anticipatory guidance and all the stuff that all of our pediatricians did. And so there's a gap that's developing, and the only way to get that gap to fill that makes rational sense is to have people move up and then fill in from below. And you can see, for instance, things like group visits for parenting led by a physician assistant who's skilled in that, or a child development person, is an excellent way to do that. The pediatrician doesn't have to spend time doing that, and the nurses in the office probably don't. So that's a concept that I think grows out of the medical home. A lot of us, everybody in the pediatric medical home national movement recognizes this, and we talk about it quite a bit. And I think you're starting to see it now in general parlance about healthcare reform. So that's pretty much all I have to say. I appreciate your taking the time to listen, and certainly would entertain any questions if we have a couple minutes.
Probably had to leave for
and
class
I do too, but I have a few minutes.
If any of you have questions for Dr. Klitzner?
Do you have a next step in the research that you intend to do?
Yeah, well, so now there's two things that are happening, and I give a whole talk on quality improvement. This is now really moving into the area of quality improvement. So the methodologic design for a lot of this follows quality improvement science, not pre-post control groups. So as we're developing here are the programs we're currently developing. We're expanding our Tier 3 medical home to include all the patients served at UCLA. We're moving into adolescent clinic. This is a hotbed of complexity because adolescents in general are complex, they're older. We're moving into these chronic care management programs in, as I mentioned, asthma, diabetes, obesity, and various forms of bowel disease. And we're also trying, and this is going to take a while, but develop relationships into the community to see, for those patients who don't come to UCLA, how we can help with that part of the pyramid as well. We're doing quality improvement projects in all of these areas, for which we need evaluations, research, design people and stuff. And then, fortunately, there's some money in this grant to do that. I think we haven't moved forward with it because we're just getting our first FTEs in place. We don't have computers for everybody yet, but that would be the idea, to look at each of these individual components as a quality improvement stream and follow it in an evaluation science kind of way.
I'm fascinated by a lot of what you talked about, especially with the cost structure. Mm-hmm. Could you speak a bit to what the implications of your findings in your study are to the way in which specialists, I guess the payment structure among the medical field itself with specialists in primary care?
So, well, I mean, I'm not sure I can start with the utilization. So one thing about payments that's really important, and I think a lot of people miss this, is you need somebody to pay and you need someone to receive the payment. And so, for instance, the term ACO has almost lost all of its meaning now because you can't figure out which side of the payment scheme the ACO is on.
Well, why don't you say what that is?
Oh, I'm sorry. Accountable Care Organization. It's a term that we just got the rules from the Center for Medicaid and Medi-Cal Services on what an accountable care organization is. An accountable care organization is really a delivery system that receives payment, usually from a health plan or from the government, for a set of services. But a lot of people are defining it more like the old health maintenance organizations that both pay and, I mean, they can be plans or delivery systems. So if you're on the delivery system side, which means you're on the provider side, you're getting paid to deliver this care. Here's some interesting things about value. We're currently largely in what we call a fee-for-service system. And in a fee-for-service system, it's piecework. If I examine a patient, I get paid. If I do an EKG, I get paid. If I do an echo, I get paid. And consequently, what the medical home does is decrease the income stream to UCLA because we cut out emergency room visits that we were getting paid for. The fallacy there, which is the misaligned incentive, you've probably heard that used a lot, is that the incentive actually is for the physicians to do more because that's how they get paid. So what a lot of work is going on is to switch over to what are called bundled payment systems, where you're getting paid either for an episode of care, a specific disease through a period of that disease, or for a period of time for that patient. And that's the premise on which these utilization curves become important, because then if you save costs at the high end of your population, you actually can keep that money. In the case of for-profit healthcare firms, that becomes profit. In the case of places like UCLA, it becomes something we can reinvest in new programs. So, I mean, this whole payment issue is huge. You're going to hear a lot about it. I mean, the Supreme Court's going to decide about the individual mandate, which we probably don't have time to get into, but that's going to be a huge part of whether you can do this or not. So I think it's a good question. It's probably a whole other lecture.
I wanted to follow up that question and ask about the issue of culture, because you described the structural changes and the constraints or the incentives that can be provided by the form of the payment system. But there are also issues of culture, and you spoke about one of them actually in terms of the most complex patients, trying to get the subspecialists to talk to each other. Mm-hmm. You said, you characterized as almost impossible. And yet that's a critical part of altering the organizational culture to facilitate medical home and coordinated care and increasing the value. Could you speak to that and how,
Sure. I mean,
how you see that evolving within the UCLA program?
It's huge. I don't know. There's a great article, which was an interview with Brent James. Brent James, you probably know, is the head of Intermountain Health. Intermountain Health is an integrated healthcare delivery system with a corporate structure. I mean, you would think that he could just tell people what to do because he knows how to make this system work. Well, even within Intermountain Health, he found that the docs just pushed back and said, this is a terrible idea. We don't think we should do this. We don't want to do it. So the cultural components of change and change management are hard in any setting. In an academic medical center where we, by the way, value academic freedom for a clinician, that means I get to do what I want to do, it's extremely difficult. I think that the levers that we have are one, payment mechanism. As long as the payment mechanism is aligned with large variation in practice, which is the problem with individuals doing what they want. And if you've studied any quality improvement at all, you know the hardest systems to improve are ones that have large variation. So as long as we have that aligned system, we're pretty much going to be swimming upstream. I think we're getting more and more into capitated payment systems and bundled payment systems. One of the reasons I want to do this pilot for these CCS kids is I want to see how that works. I believe, and there's fairly good evidence, that when you start changing the financial incentives, at least at the very top, you start getting behavior change pretty quickly. But I also think it's going to take a cadre of change agents who go out and actually explain why this is working. I mean, how many people know what CI care is at Hell Hospital? This is a fascinating thing. So David Feinberg, who's the new CEO, just became CEO, wanted to change the view that people have of Reagan, of the big hospital. It's not working so well in pediatrics, but it's worked tremendously well in the hospital. And there is a question on a questionnaire that the patients get when they leave, which the basic bottom question is, would you refer a friend to this hospital? And that's the one everyone measures. And we were pretty good for a medical center, academic medical center. We were 80-some%. We were in the top 99% of, well, I'm sorry, we were in the top 80% of all hospitals in the country, and we were, but what they did, and this is a whole program called CI Care, and it stands for something, but the way CI Care works is when anyone walks in a patient's room, you introduce yourself, you introduce all the members of your team, you tell the patient what you're going to do before you do it, and there's one other, and then when you leave, you say, is there anything else I can do for you? That's the whole program. All the nurses do it, all the techs do it, all the respiratory therapists do it, the docs not so much, but our patient satisfaction on that question is now up with the best small community hospitals. There's only 2 or 3 hospitals in the country that get a better score on that question than we do. That culture changed, and there was no financial incentive as far as I know. It was a great leadership team approach. Now, they weren't the docs, and I'll grant you that's where the culture changed from. But it is possible to do this. It's an amazing statistic what we were able to do with this program.
But wouldn't you say that, at least for patient and family satisfaction, that the real interface is between everyone besides the doctor?
Yeah.
And so that's who you want to change anyways, because people can chalk it up to, oh, they don't have bedside manner, they're busy, whatever, but it's the rest of the support staff that really affects the family satisfaction.
Yeah, I think that's true, and just in regards to the actual doctor question, that support staff has more influence with the physicians than you would think, I mean, particularly the nursing staff. But I think that if we can generate the appropriate changes using the appropriate change agents, we can make this thing change. Look, here's my one piece of evidence. I mean, it's weak and it's somewhat financial, but I'm a member of the American College of Cardiology. I mean, I'm a pediatric cardiology section, but this is the $10 million a year catheter-toting, MI-curing docs who, in the suburbs of most major cities, are among the highest earners of any professional in the area. They, for years, have practiced in these small 1- and 2-person groups because that's the way they could maximize profits. About 3 years ago, they started being sessions at the American College meetings every year on integrated systems, accountable care organizations, and more importantly, the docs started signing up with hospitals to be employees because they saw the handwriting on the wall. Their incomes weren't being affected yet, but they felt that this was the wave of the future. They needed to integrate. And in many states, not the state of California, the easiest route to integration is just to sign up for the hospital, particularly if you're procedural based. So I was just shocked, and all of a sudden I spent my time at the college meetings going around learning about the medical home and geriatric care, chronic care programs and stuff like that. You know, it's a small window, and cardiology is only one example, but it's where I live, and I've seen it start to happen.
Thank you very much.
You're welcome.
And I think in Paula, when is the